Welcome to Workshop 6, Anxiety. So we're going to start off this lecture by talking about how we can define anxiety, particularly in relation to fear. We will discuss a variety of different measures that we might be able to use and in relation to panic. We'll talk about phobias and how we can make sense of these in relation to anxiety. And we'll finish off by addressing what the severe warning signs are. In the face-to-face workshops, we'll discuss and practice some techniques we might use with clients to support them with anxiety-related issues. So in contrast to stress and fear, anxiety is more of an imprecise fear of an unknown threat. And this fear is typically, if we have clients presenting with anxiety issues, they tend to see the anxiety as excessive for the situation. And so that sense of threat is typically unrealistic in some way, but not always. There might be situations where they think the anxiety is quite valid. It's usually quite persistent, and it's often associated with rumination and worry. It can also be a state of uncertainty when people act without guidelines, and in those instances you'd often find that there's a particular thought around the level of threat and the consequences that might occur if somebody doesn't perform well. So in contrast, we can think about fear as more of a response to a more specific and known threat. The threat tends to be more immediate and precise. However, the distinction between fear and anxiety is and can be a bit vague. So fear can cause anxiety and anxiety can cause fear. And in relation to stress as well, people might experience a certain level of anxiety over a period of time, which can lead to heightened levels of stress. And persistent stresses over periods of time can lead to a more durable anxiety. So one way to conceptualize anxiety is to see it as a response to repeated events that provoke a feeling of danger. And as a consequence of those repeated threats, it may lead to persistent thoughts, anxiety-related thoughts, and what are called safety behaviors. And safety behaviors are protective behaviors that people engage in that they think they have to do in order to mitigate the threat. So, for example, it might be wearing a lucky pair of socks, always carrying a coffee around with them, or any kind of small, simple behavior that's designed to protect the person, but actually in the long run might actually maintain some of the symptoms of anxiety. And the reason why safety behaviors tend to maintain anxiety is because the person never actually learns that they're able to perform a particular activity without engaging in that safety behavior. And so they believe that it is actually dangerous and they need to persist with that safety behavior in order to cope. It's important to note that when people suffer from anxiety-related symptoms, it does impact on their physiological behavior and their physiological responses, and it can then impact on how they appear to other people and behave. So for instance, somebody with social anxiety might suffer from difficulty speaking in public, and possibly it can impact stuttering, and as a consequence then that'll impact how they appear to other people and how people behave towards them, and that can reinforce the anxiety and result in a vicious cycle. So many of the symptoms of anxiety are similar to some of the symptoms of stress, and it's because a lot of the same kinds of hormones are involved. So people will experience things like heart palpitations, increased breathing rate. Sometimes they'll experience numbness in the hands and feet. They'll experience sweating and muscle twitches. Often there'll be sleep disturbances. Sometimes that will be associated with worries and rumination. When people experience really quite high levels of anxiety, sometimes they report vomiting as well. At particularly severe levels, possibly they experience depersonalization, as if they don't really feel like they are who they are. They'll experience, on occasions, chest pains, need to urinate over a period of time, perhaps exhaustion, aches and pains, loss of appetite, weakness, difficulty concentrating, feeling faint and dizzy. It can impact headaches, often because of the tension in the muscle areas around the head, and stomach pains and cramps. So you'll notice there's quite an array of different symptoms, some of which are often interpreted as medical issues, but nevertheless they can be explained at times as symptoms of anxiety. So panic then is a more pronounced and extreme form of anxiety that some people will experience. A panic attack itself can last anything from a minute to a few minutes, maybe 10 minutes or so, and the symptoms or the experiences are often reported as extremely severe. So people might experience overwhelming fear, thinking that they're dying or losing control, increased heart rate, difficulty breathing, excessive perspiration, and feeling faint, dizzy, or lightheaded. This is a quote from Edvard Munch, who's the artist who painted The Scream, and some people have suggested that this painting represents what it feels like to have a panic attack. So he reported this as, "I paused, feeling exhausted and leaning on the fence. There was blood and tongues of fire above the blue-black fjord in the city. My friends walked on and I stood there trembling with anxiety, and I sensed an infinite scream passing through nature." There's perhaps a good qualitative description of some of those experiences of what it might mean to have a panic attack. In terms of what's going on in the mind then, when people experience anxiety, there tends to be a preoccupation with different kinds of threats. And in contrast to stress, perhaps it's a little bit more vague and free-floating. But nevertheless, there's a preoccupation with any stimulus that might be threatening the individual. There's often an overestimation of the likelihood of negative events, and in cognitive therapy that's typically referred to as catastrophizing, so imagining the worst possible outcome, which indeed would engender a sense of anxiety among most of us. And additionally, there's often an underestimating of personal strength, so a belief that I will not be able to cope and that I don't have the skills to manage these situations when they come up. If somebody did imagine that they had the skills and the strengths to cope, the threatening situations would seem much more manageable and result in less anxiety. So some element of this is related to the individual's capacity to manage and cope with the situation. As with many mental health issues, one of the behaviors that can tend to maintain anxiety is avoidance. And when people avoid situations that they're afraid of, it can mean that it maintains this belief that the situation really is scary, and it prevents people from being exposed to new learning opportunities where they discover that they actually can cope and the situation isn't as frightening as they thought it was. As I mentioned earlier, another behavior can be to only engage in this situation when safety precautions have taken place. For people with social anxiety, this can be, for instance, drinking alcohol before going into certain situations. And when they do this, unfortunately, they learn that the only way to cope is by drinking, and without that safety behavior, they're unable to cope. So a safety behavior can actually, as I said before, maintain anxiety also. Just going to show a short video now of people describing some of their symptoms and experiences of anxiety to give you more of a qualitative sense of how clients might present in counselling.
I think the cause of the anxiety for me was probably a traumatic experience in my life and maybe suppressing a lot of the things that had happened to me and not dealing with the issue there and then, and it all sort of coming more back out.
My situation stems from depression with the breakup of a marriage, which was about 4 years ago. I think I started having what turned out to be anxiety attacks probably 12, 13 months after that.
Bullying took a big part in my life because not being accepted and people calling you names, and you just think, hang on, what's wrong with me? What do I do wrong? You look at every single thing.
Lunchtime I walked up Swanson Street, near the intersection of Burke Street, and bang, this anxiety attack came on. I remember putting my arms around a power pole or something, and I saw a workmate walking up the street. I said, God's sake, I'll get a bloody ambulance.
When I do get stressed and can't cope, I just tense up, and I can feel myself doing that. I didn't at the time realise that that's what it was, and of course the more it would start, the worse it would get. But yeah, it would just cause my stomach to spasm, and I'd end up with diarrhoea, and it was just ongoing.
I've probably always had like a low self-esteem as well, and it probably coincides with it. And yeah, so I guess that's another factor that comes into it. Or sometimes I feel like that's like the underlying problem.
The job I do as a bed and breakfast proprietor is pretty simple. I always tell people I could probably train a monkey to do what I do in less than a week. It's simply, I get up in the morning, I set tables up. I've only had to cook breakfast for 6 people. I don't have a dining room full of hundreds of people. I cook breakfast, I clean up, and they go and do their thing and I do mine. So having done this nearly 6 days a week for 7 years, getting up in the morning and throwing up and having absolute fear of having to do what I'd been doing for the last 7 years, it was driving me crazy. I was just like, why am I feeling like this?
You realise from an early stage what sort of things trigger your anxiety. Well, for me, it's like being around a lot of people or having like a lot of attention placed on me.
Looking up at the sky, going to the beach, I'm thinking about space. The thought of space freaks me out. In fact, how are we here? And the fact that I never know that, I will never know that probably, really makes me anxious, and it feels like I'm not real.
Nervousness, shaking, which I'm probably presenting now, sweats, hot and sweaty, headaches, a lot of nausea, that type of thing, tiredness, achy.
Sometimes I'd just wake up in the middle of the night and I'd get this intense fear, and my heart would race, but it was never because of anything. It was just there.
Owning my own business, I rely very heavily on my phone and on the internet. The phone would ring and I would sit there and look at it, because I knew if I answered the phone I may have to write a confirmation, and I couldn't write. My handwriting was just all over the place. I couldn't even read it.
It takes over your life. It stops you from doing things you want to be able to do. You want to be doing what everyone else is doing, and you feel like you can't.
It was stopping me from doing a lot of things. I wanted to do things in life, and I wasn't able to do them because I was always frightened. So yeah, that's when I decided that, yeah, now's a good time to fix me.
Just going to talk now about a few different measures that you might use if you have clients present with anxiety to get a sense of how severe some of the symptoms are. The Depression, Anxiety and Stress Scale, of course, includes a subscale of anxiety which allows you to determine how severe their symptoms are relative to a broader population, which is great, and you can use that then to substantiate any evidence from your evaluation session which might indicate that the client might require a referral initially. For clients who report panic attacks, we could use the Panic Disorder Severity Scale. And if we notice that clients are reporting severe panic symptoms and repeated symptoms of panic, that might indicate that a referral is required. Just because somebody has some experiences of panic doesn't necessarily mean that they require a referral. Nobody has ever died from a panic attack, but where people are really unable to leave certain places or visit the supermarket or do really simple activities because of their panic symptoms, they might require some short-term pharmacological intervention just to help them cope so that they're able to engage in simple counselling techniques to actually make longer-term improvements. So with the Panic Disorder Severity Scale, this is a very short measure which makes it easy for us to deliver in a session. It provides a brief description of what panic attacks are, and participants respond to each item from 0 to 4, indicating how much each symptom impacts on their functioning. And a score above 9 might indicate the need to refer the client for medical support. Of course, that's not an absolute number, and we have to substantiate that with other observations and evidence that we gather during our work with the client. So the issue of phobias is very much consistent with anxiety as a problem, and indeed often a good area to provide support to somebody with if the phobia is interfering with their day-to-day life. So we can conceive of phobias as an excessive and unreasonable fear of something, of a place, event, people, or an object. And essentially one of the things that keeps the phobia going is some kind of avoidance. So people will avoid whatever the phobia is, and as a consequence people will continue to believe that what they're afraid of really is dangerous and highly threatening. You can typically see the emergence of phobias from childhood or adolescence. It's not necessarily related to a really frightening situation or trauma. It can be, but it's not necessarily. Children often develop fears of unusual things as they're growing up, and I think this is just part of our evolution, really, our protective instincts to keep us safe from things which might seem dangerous or overwhelming. What's important then, I think, is how children behave as a consequence of that initial fear. If they continue to avoid whatever it is that's created that fear, they may grow up with a particular phobia of that situation, of that person, of that thing. However, if they're able to gradually confront what they're afraid of and they learn that it's not so scary, they won't maintain that phobia into adulthood. Sometimes it can be a result of modelling parents' behaviours. So if a child observes that a parent is absolutely terrified of spiders, they'll also learn that spiders should be terrifying and this is an appropriate way to react. It's unusual that it comes out of nowhere, but I wouldn't spend too much time worrying about where the phobia comes from if you're unable to develop any reasonable hypotheses. You can still use systematic exposure with clients, even if you're not too sure what the phobia is about or where it came from. So there are lots of types of specific phobias that people might develop, everything from spiders to cheese, to flying, to rain, to lightning, dogs, open spaces. There's a huge variety and more than I can discuss during this lecture. And some of these phobias are going to be more have more of an impact on life than others. Essentially, if the phobia is something the individual has to come across in different aspects of life and results in more avoidance behaviours, the phobia is going to be more debilitating. So for instance, if somebody's afraid of dogs, it's going to limit a lot of places they might be able to travel. But if they're afraid of clowns, it may be less likely that they are going to be disturbed by that very frequently. Social anxiety is also sometimes referred to as social phobia, and that's probably a fair description. And it's very common too, so it's an excessive fear and consequently avoidance of social situations, and that's partly what maintains that fear. This is very common, and it's often a good issue to discuss in counselling, although we'd have to be careful that it's not so excessive that the individual is unable to access a lot of social situations altogether, in which case some medical support initially might be appropriate. A common phobia also is agoraphobia, fear of open places. That can be more or less extreme for certain people. Where people are completely afraid of leaving the house, we would rarely see these clients in counselling, but they may require some more intensive support initially. So these phobias, social phobia and agoraphobia, they can be particularly disruptive on occasion, and as I mentioned, might require some more intensive initial support so the individual is able to access therapy that will provide the longer term support that they require. Systematic exposure is a really effective way of supporting clients with phobias, and in the workshop we will discuss systematic exposure in more detail, but essentially what it is about is just gradually exposing people to the situation that they're afraid of, and at each level, at each incremental level of exposure, we teach the client to cope using various strategies and skills so that they're no longer afraid, and through that avoidance the fear is the maintenance of that phobia is broken, and it tends to be very effective if it's done gradually and the client feels they have some control over the process. So there's just a couple of other severe symptoms that I would encourage you to look out for that might require referral to medical support initially. One of them is mutism, where the individual simply is unable to speak in many situations. Of course, that's going to make counselling incredibly difficult, and so initially we're going to have to try and use some other kind of support to help this client, and the psychiatric evaluation is sometimes a good place to start. Where individuals report recurrent panic attacks, and we're talking more than once a week, and they're very severe and debilitating, this person might also require some kind of anxiolytic medication. Typically with that medication, it's take as you need it, and in that way the client sometimes just develops some reassurance that the medication is available to them, and that in itself can act as a way to reduce panic and anxiety. Where people have a lot of anxiety over lots of situations and there's severe symptoms as assessed from your evaluation and the measures that you complete, this might also require some initial medical support so that the client is able to get a grasp on those symptoms so that it can reduce some of the severity and make it easier for them to engage in counselling. Obsessive compulsive disorder is also within the anxiety category of issues. When people have OCD, OCD used to be considered a purely psychological issue, but as it turns out, in fact, it does represent a problem with the feedback loop in the brain. Most of us, if we think we've left the oven on at home, are able to say, no, it's okay, everything's fine, I remember turning it off. With somebody who has OCD, they might tell themselves this, but it doesn't seem to impact on the levels of anxiety that they're experiencing, and therefore it represents a problem with that feedback. People with OCD also typically experience really severe intrusive thoughts, and what are called true obsessions, which can almost seem a little bit psychotic, a little bit unusual. However, people with OCD rarely have, or they don't actually have hallucinations, but they experience true obsessions, which are unusual beliefs about something that they've done and that they need to do. In order to cope with these obsessions, these intrusive thoughts, people with OCD will engage in repetitive behaviors. The classic one is hand washing, but it can include things like asking people to tell them that they're okay, and other kinds of reassurance seeking behaviors. These repetitive behaviors serve to teach the client that it's okay, that they can relax, but they don't have the effect of creating any long-lasting change. So people with OCD, you'll notice them because they have intrusive thoughts that really bother and disturb them, and to try and cope with those thoughts, they engage in repetitive behaviors that seem to ameliorate the symptoms for a short time before they have to do those behaviors over and over again, and it can become incredibly debilitating and severe. So for these clients, we need some kind of psychiatric assessment, so that we can be sure that they're provided with the kind of support that they need. On occasion, that might require intensive support in a psychiatric environment, because the treatment can be intensive exposure to the anxiety-provoking thought, and that can result in some very severe symptoms and require a lot of support around the client to be able to manage that. One of the more unusual set of symptoms people can experience is hoarding, which results in excessive accumulation of items and distress about losing those items. The treatments for hoarding are not that great in terms of how effective they are, and it often requires actually visiting the client at home too, so it might require social work support. So for these clients, we'd want to make sure they're referred to a specialist who has expertise in that particular area. Some individuals engage in skin picking and hair pulling, and we have to assess the level that that's affecting that person's health. But if we think that it's causing the individual significant any risk of harm, we might require referral to medical assistance. There's also an issue where people have really severe anxiety about their health, hypochondriasis, and this is very difficult to treat. And these individuals might also continue to seek medical support. With this particular group, I would encourage you to consider whether there's a specialist that you're aware of who is able to support this client if it's more severe, because it's very, very difficult to assist somebody in the long term to change the anxiety around health.